and we're going to complete our day learning about prevention in the older adult. And I'm here with Dr. Nisha Ragwani, who I'll give her brief introduction. She was trained in the UK, where she went to medical school at the University of London and also pursued a residency in family practice. She then moved to the United States and came to Mount Sinai, where she pursued a fellowship in geriatrics, followed by her faculty appointment. And she's now a professor at the Brookdale Department of Geriatrics and Palliative Medicine. She spends most of her time in the outpatient practice, where she teaches fellows, residents, and medical students. And she's the medical director of geriatrics and palliative care in the outpatient practice at Mount Sinai Morningside. And we welcome her here and can't wait to hear everything she's got to say about prevention in the older adults.
Thank you so much, Dr. Bhatia, and good afternoon. I'm sorry to I will apologize in advance that I'm going to be racing through this a little bit at this late hour in the afternoon. So bear with me and thank you for being here. I have no relevant conflicts of interest to disclose today. I'm hoping by the end of my session with you today, you're going to understand some principles of screening that we apply to older adults. Kind of how do you make these decisions, what you screen for and what you don't, and then how we can kind of promote some health interventions to be effective in older adults. So just to recap, health maintenance really is health promotion and prevention. And I'm going to spend the bulk of my talk talking about this kind of primary and secondary prevention, primary being immunizations, and then secondary being screening. And that is trying to detect some of these more kind of serious illnesses, primarily cancer. Just to recap again, you have usual practice where you may have a biological onset of disease, and then you have symptoms at which point you're going to start investigating, and then that perceived survival time may be shortened. However, with screening, you're trying to detect this disease earlier than before symptoms come up and hoping to improve that kind of perceived survival time, giving you some kind of a lead time. So some of the immunizations in older adults, this is a summary sheet, right? We want to focus for our older adults, immunizations, which is annual, a COVID vaccine and booster, and I'll get into that a little bit more, the RSV vaccine, a tetanus booster, pneumococcal, and Shingrix. So RSV kind of came about, I want to say, a few years ago, 2 to 3 years ago, primarily because we had this triple-demic in 22-23 season, where there was this increased risk of death and hospitalizations from COVID, flu, and RSV. So that is kind of this big thing that came across. So we'll talk about that in a minute. So influenza vaccine studies have shown that high dose is much better for older adults than low dose, primarily because as one ages, their immunity wanes much quicker than when you're younger. This flu season, we are giving the high dose inactivated influenza or the adjuvanted inactivated influenza, and that's like the Fluad and the Fluzones. The high dose has about 4 times the antigen amount, so elicits a much stronger response in an older adult. If those of you who are very interested in what kind of strains we're looking at, this kind of will tell you it's the strains that are in this year's vaccine. Primarily the A/H2N2 virus has been updated and all will be trivalent this year. COVID. There's been a lot of stuff in the press recently that I'm sure everyone's aware of. For older adults, it's not that much of an issue because anyone over 65 is recommended to get the COVID booster. There is this new COVID variant called the XFG or the Stratus, which has been spreading. Moderna, Pfizer, Novavax have all come up with some new vaccines for this year. In pediatrics, there's still some question out there, but primarily if you're older adults, 65 and over, or actually those who are younger who have any kind of underlying condition that puts them at high risk will be able to get the COVID vaccine. In New York now, you do not need a prescription. Some states, however, you still do. The If you've had COVID, if someone has had a COVID infection, they need to wait 3 months before they get a COVID booster. And in general, if they've had the older vaccine before, then they need to wait 2 months. So that's the big change. That's kind of because there's the people have just been getting it every 6 months, and then some people have had it more recently. Um, right now, it's thought to be every 6 months still. RSV, it's recommended that people need to be 75 and older. Now, if they're in that 60 to 74, an increased risk because they have one of these risk factors, either chronic heart, lung disease, a weakened immune system, severe obesity, severe diabetes, or they live in nursing homes or other long-term facilities, they are suggested that they get the RSV. It is not currently an annual vaccine. It is currently and only one dose one. And the preference is to get it late summer, early fall, but not necessarily. And again, there are two types of RSV vaccines, Arexvy and Abrysvo, single dose. And overall, you can kind of see people, if you look at this graph, people who had placebo versus those that had the RSV vaccine, kind of the incidence was much lower in people who had the RSV vaccine. Overall symptoms were also much lower with people who got the RSV vaccine, got RSV, they had less pain, less fatigue, and their overall were much better. Pneumococcal vaccine, strep pneumoniae still remains a leading cause of pneumonia, meningitis, bacteremia among older adults in the United States. Older adults over 65 has been, high hospitalization rate. And this is kind of the serotypes that they found based on the different vaccines they've created. Currently, and you can see from this graph, once they introduced this PCV13, and once it was always PCV, not always, but it was PCV23 for a very long time. And then they introduced 13. You can see that the cases of pneumonia actually decreased. And the solid line the solid with the dot line up here is our population over 65. That's our older adults. And you can see once they introduced these newer vaccines that took care of more serotypes, that actually the incidence dropped off. Here it's kind of flattened because this is where we've been tackling those particular serotypes. Currently, these are the recommendations. Adults over 50, if they've never had a vaccine before, they should get the PCV 20 or 21. If they've had the 15 before, they need to wait a year and get the 23. If they've had, so this is for the PCV 15 only. Again, they get the PCV 23. If they've had the 15 and the 23, or the 20, or the 21, they do not need any more vaccines. If they've only had the 23 in the past, then after 1 year, they need the 20 or 21, or they can wait a year and get the 15. If they've had the 13, they need to wait a year and get the 20 or 21. And if they've had the PCV 13 at any age or the PCV 23 less than 65, then they need to wait about 5 years to get the 20 to 21. So these are some of the new recommendations that are out there. Again, shared decision making for those who've already completed the 13 and the 23, which was the gold standard for a while, as to whether or not they want to wait 5 years before they get the new 20 or 21. You need to wait in immunocompromised patients. You want to wait kind of a minimum of 8 weeks. Between any kind of vaccines, ideally, if they have an immunocompromising condition, any cochlear implant, or any cerebral spinal fluid leak. Shingles vaccine, really, really important. This is a recombinant subunit type vaccine. It's actually a two-dose vaccine, and the second one is 2 to 6 months after the first. The age cutoff is they say people over 50 should have it now, and this is a little different to Zostavax. And anyone over the age of 18 who is immunocompromised needs to get the shingles vaccine. Very efficacious. You can see in our older adult age group, it's about 91% efficacious. It is a good vaccine for immunosuppressed patients because it's an inactivated one, which is different to what Zostavax used to be. If people have had shingles previously, they can get this vaccine again. If they've had Zostavax, they can get this vaccine again. There's also some other kind of evidence-based screening annually. So health, height and weight, a BMI, blood pressure, lipids, vision, hearing, depression, alcohol, substance abuse, falls, cognitive impairment, and elder abuse. So these are USPSTF says over 65, these are what your patients should be screened for. We'll start with hypertension. It is definitely a USPSTF grade A recommendation that all adults over the age of 18 should be screened for hypertension with an office blood pressure measurement. Hypertension affects about 45% of our adult US population, which is pretty significant and one of the most commonly diagnosed conditions, leading to cardiovascular death, disease. Screening super easy, very beneficial. And actually any age group benefits. So there's some new ACC AH8 guidelines this year that just came off, where they talk about what is normal, what is elevated, stage 1 and stage 2. So normal right now is 120/80, and this is no different in the older population. And this is based on an average of more than 2 different occasions that you are taking blood pressure. So part of these new guidelines is also using now a risk calculator to help kind of figure out who should get treatment and who shouldn't. I've kind of put a little snapshot of it, but if you just go into Google and look for Prevent Risk Calculator, it will come up with it and you can fill it out and it will tell you what you should and shouldn't be doing for our patients. Some of the new things that have happened recently, they're thinking more about cardiovascular, kidney, metabolic factors. And new this year is the social determinants of health is really important. General consensus, if someone who has hypertension, no CVD, plus a 10-year risk of CVD greater than 7.5% should get treatment. And the other group that should are those also who have hypertension, CKD, or diabetes who have no CVD, plus a 10-year risk of CVD greater than 7.5% should get treatment. I encourage you this is not a hypertension talk, so I'm not going to spend too long on it, but I encourage you to go and look this up. They have really nice algorithms to help you work through. What's really important this year, though, is that at every stage, both normal, elevated, stage 1, stage 2, they are now including lifestyle as a primary and very important treatment, non-pharmacological treatment method for everyone with hypertension. The other thing, as I mentioned, so it's a mix between hypertension, lifestyle, and medication. And they're saying that drug therapy should really begin earlier if the blood pressure remains greater than 130/80 after 3 to 6 months of lifestyle management. So try the lifestyle first. If it's still elevated, you need to start taking medication. And then in those higher risk groups, the diabetics, the chronic kidney disease, high CVD risk, we should really be thinking about starting control pretty promptly and not waiting those 3 months for lifestyle. So as I mentioned, they talk a lot about lifestyle. This includes the DASH diet, cutting sodium, reducing alcohol, managing stress, weight loss, physical activity, and home blood pressure monitoring. And now they're also introducing kind of using more diagnostic tools, such as doing a urine albumin creatinine, and also screening regularly for primary aldosteronism in resistant hypertension, even if they don't have hypokalemia. They've also made a large connection to cognition in these new guidelines, and really kind of promoting this team-based care and accurate measurement. They also have drug therapy guidelines, using thiazide as first choice. Chlorthalidone actually preferred over hydrochlorothiazide because it's got the sustained action and superior cardiovascular benefits. Then they're thinking about for African American patients to be using calcium channel blockers as first line. And then, of course, with our diabetic CKD, particularly if they have any albuminuria, using our ACE and ARBs. And then for patients who have CHF or after an MI, to be using beta blockers. So not too much change there. They also talk a little bit about stage-based approach. So I will let you spend time reading these slides because, again, this is not primarily a hypertension talk, but I wanted to just, because there were new guidelines, I wanted to put it out there. Hyperlipidemia, again, grade A recommendation for routine screening for men over the age of 35 and women 45. However, for if any they have any cardiac risk factors, then for men, actually, the screening is between 20 to 35 and for women 20 to 45. Any identification of hyperlipidemia decreases mortality. And again, a lot of benefit is seen across the ages for this to be both recognized and treated. A wonderful meta-analysis of 28 randomized trials looked at over 185,000 people. And it was a 5-year follow-up, and they really showed that with the use of statin, there was a significant decrease in major vascular events across all age groups. So again, a significant 21% reduction in risk with each 1 millimoles per liter reduction in LDL. So really impressive. And then there's some recommendations as well for low to moderate dose statins for people who are age 40 to 75 without cardiovascular disease, or those who have some risk factors and a 10-year CVD risk of greater than 10%. And then for people who have this 10-year CVD risk, which is anywhere from 7.5 to 10%, to selectively offer that. There was insufficient evidence to really weigh the benefits and harms in patients who were older than 75. So a lot of the studies, unfortunately, do not always capture our patients who are older, but at that point, it's kind of looking at your patient, looking at their risk factors, looking at their preferences, looking at their mortality and morbidity risk. Breast cancer, the recommendations of biannual screening for 40 to 74-year-olds. Unfortunately, insufficient evidence for older than 75. Over the years, breast cancer has decreased in, when over the age of 50, there has been a dramatic decrease, especially since some of these screening guidelines have been out. So, really thinking very carefully about wanting to make sure we are screening or advising our women to be screening. There was this ACOG guidelines in 2017, which haven't changed, is actually to offer screening as early as 40, and women are not starting at 40, definitely by 50. And this can occur every 1 to 2 years, and it depends on the patient's preference. And actually over 55 screening every 2 years was not unreasonable. So it was fine to do that. So because there are no guidelines as to what to do after the age of 75, the decision's really to have that discussion with the patient, whether they want it or not, whether they would do anything or not, and then kind of looking really important at their current life and what their life expectancy is. And I'll talk a little bit more about how we can judge that and how we can use those tools when we counsel our patients. Cervical cancer, I have seen too many older women in their 80s and early 90s who are still getting pap smears. if a woman is over the age of 65, has had 3 normal pap smears on previous screening and 2 negative cytology and HPV tests within the last 10 years, they do not need to be screened any longer. So bear that in mind as we're talking to our patients. As they get older and with menopause, those are very painful exams, and we do not need to have our patients be doing things that are going to not be very pleasant for them. Colorectal screening, age 50 to 75 is the recommendation. The USPSTF is recommending against screening for adults over the age of 85. And then between 76 and 85, again, case by case basis, you want to take a look at those patients and see. They did this great study again that we looked at colorectal cancer screening in previously unscreened. And it's actually the reason I like this study because it kind of tells you a little bit about, well, what's the modality that we should be using. And this is actually something that I refer to very often, where it actually just puts out for you if a patient has no comorbid conditions, if they had moderate comorbid conditions, primarily ulcers, rheumatoid, PVD, diabetes, CVA, history of acute MI, they fall into this moderate. And the severe comorbid would be your COPD, CHF, moderate severe liver disease, chronic kidney disease, dementia, cirrhosis, chronic hepatitis, and AIDS. It helps you figure out, where is it cost effective? So the ages that it's cost effective, if, what modality, whether it's a colonoscopy, sigmoidoscopy, or the FIT test. So really nice to kind of go back and say, okay, these are my patient with these conditions. What should I be recommending that they have? Number 1, should they be screened? Number 2, what is the modality? There was also some updated guidelines that came out based on tiers. If they had a colonoscopy, do it every 10 years. If they had a FIT test, do it annually. And they go through very nicely what the various tiers are. Average risk tier 1 was age 50 for non-African Americans and age 45 for African Americans. The great thing about this was it started to look at family history rather than this blanket, oh, everyone should get screened if you're this age. So, if they had one first-degree relative that had a CRC or an advanced adenoma diagnosed at less than 60, or 2 first-degree relatives who've had that at any age, when should they have, they should have colonoscopy at 10 years younger than the youngest age at the diagnosis of the first degree relative. So this is, again, a very nice model to help us think about that family history and also looking at race, which we know does unfortunately affect the incidence of these diseases. Age 75, if they've had negative screening tests and if their life expectancy is less than 10 years, then they need to discontinue colonoscopy. And anyone over the age of 85 who've never been screened and never had any issues can also discontinue. Then I want to talk a little bit about the FIT test. They're kind of moderate to high sensitivity. And I think a lot of our patients may not want to have colonoscopies. So just kind of educating patients, families about that FIT test is not always necessarily a second best strategy, and that actually for some patients it may be actually very good. The only one thing to bear in mind is that there is a higher rate of false positive in older adults. So having that discussion upfront, super important. Cologuard screening test for colon rectal cancer detects this altered DNA in the stool. Pretty sensitive, pretty specific. Again, really ideal for those patients who aren't horribly keen on getting a colonoscopy. They detected about, in the study they did 69% of high-grade dysplasia versus 46% with the FIT. So, and again, having this every 2 to 3 years is pretty reasonable. Lung cancer, USPSTF does recommend annual screening with low dose CT, and they're pretty specific about, and if you go and order it in Epic, a lot of times it will not allow you to do that because your patient does not fit the criteria. Age 50 to 80, they have to have had a 20-pack year smoking history or currently smoke or have quit within the last 15 years. So really important guidelines. Do not need to have this if they've not smoked for 15 years. If they have developed any other health problem that substantially limits their life expectancy, they should not be having this anymore. And the other big conversation that needs to happen is what is their ability and willingness to have any curative lung surgery should something be found. Okay, and that's, I think, the important thing. These are very sensitive, and this very large national lung screening trial looked at what the incidence was, and it was definitely lower. It was a lower incidence from lung cancer and lung cancer specific mortality. Some people worry that over frequent screening has some harms. And, there's been some talk about whether that interval between screens can be looked at. And again, you need to have those discussions with your patients. Prostate cancer screening has also changed in the last few years. The USPSTF really recommends against PSA-based screening for prostate cancer in the general population, regardless of age. However, this was changed in 2018, and they looked at 55 to 69-year-olds that actually the potential benefits and harms of prostate cancer screening should really be more of an individualized one. So you should be having these discussions with these younger, older adults. However, over 70, the recommendation is still no screening. Urinary incontinence, unfortunately, we just don't screen enough for. So, the Women's Preventative Service Initiative really said that women should be screened annually for urinary incontinence despite age, parity, and obesity. It's simple questions, right? Ask if they have any incontinence, but more importantly, does that incontinence affect their daily life and their activities? Most women do not want to be talking about it. However, if you ask the question, they really want to talk about it. So just keeping that in mind is really important as well. Osteoporosis, some newish recommendations from last year. Women age 65 and older actually should be screened for osteoporosis. Women less than 65 should be screened if they have risk factors such as low body weight, any prior fracture, any family history of hip fracture, smoking, and any excessive alcohol consumption or long-term steroids. And the FRAX score is really good for determining that. And then for men, they do say no screening. However, men who have any of the risk factors should be considered. And this is like a snapshot of what the FRAX score looks, the FRAX kind of index looks like, asks you, questions that you should answer, and then it tells you what their risk is. And accordingly, you can decide if you're going to screen them or not. Falls screening, super important. Why is it important? We all know falls, 1 in 4 adults fall, older adults, and 1 in 5 of those falls actually results in a serious injury, including fractures, head injuries. There are 800,000 patients a year that are hospitalized because of fall injury, and a lot of them are actually because of traumatic brain. It's costing our healthcare $50 billion. And, that's a lot of money for those kind of mortality and morbidity that's related to that. So simple questions, really important to ask the falls questions, which I'll go through. But you can see as people get older, especially in this older age group, there is a high risk of injury from falls. Simple fall screening questions. In the past 12 months, have you had a fall? Second question, have you been afraid that you might fall because you have some balance or walking problems? Ask those 2 questions. If either of them are positive, then you're going to do more of a falls kind of workup. There was the new evidence that came out that said adults who did not have osteoporosis or vitamin D deficiency, exercising kind of really important for especially for high risk community dwelling adults. Offering a multifactorial intervention to prevent falls. There's so many now everywhere that are offered. I encourage our older adults to partake in them. Vitamin D is not recommended for direct prevention of falls. Making sure they're really against this postmenopausal women just blankly taking vitamin D or calcium to have primary fracture prevention. Of course, if they're deficient, then that's different, and that they should not be deficient. Depression, really another very important screener, very common, prevalence about 14%, but I think that's higher because of just reporting. It's the third leading cause of actually losing kind of quality adjusted life years. And it can impair function, relationships, social behavior, can increase cognitive issues. So older adults actually have the highest suicide rate, secondary to depression of kind of that all age group. If you look at it, it's the highest, and it very often goes unrecognized. Again, simple screen, PH2Q, the 2 questions, little interest or pleasure in doing things, feeling down or depressed. If any of those are positive, you need to continue and do a PHQ-9. So how do I gave a lot of kind of what are some of the recommendations. Well, how do you approach that older adult? What are we going to do? So number one, we're going to think about what is their life expectancy and comorbidity. What comorbid conditions do they have? Again, life expectancy sadly varies amongst races. So there's a lot of data out there that you can kind of look at to think about life expectancy. But we have some wonderful tools. If you've ever used ePrognosis, wonderful tool. Really, you put in the data and it helps you figure out what is the prognosis, what is the lifespan of that patient given their other morbidities. And just because someone may have multiple comorbid conditions and you don't want to screen for things that may be, for cancer, there are other things that we can screen for. And falls, we can give them immunizations, depression. There's other things that are very important that would affect their quality of life. You also want to use that lag time, thinking about usually for most tests, you can see in this graph, you're not seeing much of a difference if you annually screen, biannually screen, and a control group. It's about roughly for colon cancer, they have to have a life expectancy greater than 5 or 7 years, and breast cancer at least 5 years. And on ePrognosis itself, there is a nice tool, and I can't do it here because this is not a live demonstration, but you put in all the information and you can actually move, or once you figure out what the life expectancy is, you can actually move this kind of bar over, and the green zone is where you should screen, and the red zone is where you should not. So really, fun to kind of play around with, really helpful and useful. You also want to think about cognitive status. As one has cognitive defects, so this is a person in the purple line that has no cognitive defect, and this is as the mini mental gets lower and lower, you can see that mortality actually increases. And this is the same for functional status. The less functional someone is, the mortality decreases much faster. And this is a really nice frailty criteria that one can look at. Weight loss, weakness, exhaustion, slow walking, and low activity. They need 3 or more of those. Also remember that risk decreases with age across all cancers. So as they get older, the risk of them getting something is lower, and the numbers needed to screen for that is also higher. So that also plays into your decisions. Remember, every screening test has a potential harm, primarily because there's some complication. You have a false positive. They're going to have diagnostic procedures. Something may go wrong. And then you're going to identify those unimportant, that prostate cancer that may not be that important. That's not what's going to necessarily kill them, or the breast DCIS. There's a lot of psychological distress that goes with that. And along with that, the most important is, what are your patient's values and what are their preferences? So those discussions are really, really important. This just runs through kind of a little bit what I talked about. Also important to look at mistreatment of older adults and safety as well. We talked a little bit about DEXA. Blood glucose is interesting. People who have elevated blood pressures consistently, you might want to think about that. And a AAA ultrasound, really important for men, only men right now, 65 to 75, who've ever smoked. And there is no recommendations for women right now. Calcium, so some chemoprophylaxis. Calcium's really there to prevent bone loss and mildly increase bone density. Primarily, we want that to come from food and not tablets. So same with vitamin D. As I mentioned before, they do not directly result in lowering risk fractures. And the study trial came up with a lot of important information for us. However, if people have low vitamin D levels, it is probably a good idea to give that back to them. Aspirin, for a long time, people were taking aspirin as primary prevention. However, the ASPRI trial recently showed that only people who have high risk factors should be considered. Again, huge trial, 19,000 older adults looked at aspirin, whether or not they should have it. And they actually showed that the harms here were worse than the benefits. So the current recommendations are, you only reserve that low dose aspirin for people who have the highest cardiovascular risk factor and the lowest risk of bleeding. Hormone therapy, there's a lot more people on it. Still, it is an individualized treatment, shared decision making at this point between patients and their providers. You really want to think about what's their cardiovascular risk factors, their cancer risk factors, and their other medical conditions. Multivitamins, not recommended. You prefer to get them all from food. There's been shown no difference in mortality or morbidity. Unless someone is malnourished, there should be no reason why they need to be taking that. And then lifestyle, you really want to think about the important things, right? Physical activity, you want to make sure you're screening that annually, doing the alcohol, smoking, and sexual dysfunctional, sexually transmitted disease. Body weight's really important, and that is both actually low weight and high weight. And the USPSTF is saying that we should be screening everyone for obesity and low weight. And actually, a small weight loss or weight gain can actually decrease your risk of mortality and morbidity significantly. Physical activity, you really want to promote mobility, reduce it helps with decreasing coronary artery disease, hypertension, diabetes, everything. And I think the best program is one that balances flexibility, endurance, strength, balance. And flexibility of things like stretching, strength is weight training, endurance is walking, cycling, balance, Tai Chi, dance. Each 1 MET increase in exercise actually is almost a 12% increase in survival. Again, large benefit. I like to say, if they can walk 1 hour a day or moderate intensive activity for 30 minutes, they want to do some stamina and some strength. And if they can't do any of that, at least have people walking for about 30 minutes a day, at least 4 to 5 days a week. Lots of great evidence out there for all the good benefits. And again, you can spend some time on these slides when you have the time. Eating, as I mentioned, really important. Mediterranean diet. So what do we counsel? Mediterranean diet really emphasizes fruits, vegetables, whole grains, legumes, nuts. They really want you to be using monosaturated fats, especially things like olive oil. You want to get about 2 servings a week of fish, oily fish like tuna, salmon, mackerel, herring. They do actually promote some moderate alcohol use and sparing use of meat, saturated fats, and high-fat diets. again, showed all cause mortality, like low risk for everything if you can switch that diet. Alcoholism, very important, can often go missed. So, using the screening questionnaire in people who you suspect are using a lot more alcohol, at least all adults, the recommendation is all adults should be screened at least once. And then, if you suspect, then definitely screen. We should talk about smoking cessation. We should be screening all our patients, but talking about stopping is important for every visit, even though they tell you the same thing. And the big thing here is close follow up if you're going to try and help them with some agents. We underestimate sexually transmitted disease in our older adults. And so 50, and it's not just sexually transmitted disease, it's also sexual dysfunction. 50% of sexually active older adults will report that they have at least one bothersome sexual problem. If we don't ask, they're not going to tell us. And then really thinking about what are some of the important factors in longevity. Social support systems, the ability to cope with stress, lifelong learning, meaningful activity, and laughter. And actually, they contribute much more, sometimes, definitely as much as healthy behaviors. And multiple studies have shown that if you have a good social support system and have something meaningful in your life, that it actually increases morbidity, sorry, decreases the risk, decreases morbidity and mortality. So, social life, lifelong support, stress reduction, engaging in meaningful activity, and these are good counseling things. We all get too busy. Think about some kind of a way that you can remind yourself using your interdisciplinary team, using Epic and other computer systems. My take home to you is need to be individualized, talk to your patients, counsel against all the healthy stuff. I did, so after questions, I think there were I had some questions there, but they're not there now. But I had some kind of exam questions that you can kind of look at. Sorry, that was a little bit of a sprint, but I do want to leave some time for questions.
So nice to hear that there's so much we can do to help keep our older adults healthy. So thank you for that talk, Dr. Agwani. And I love the exercise prescription, especially the one that was the simple exercise prescription and the more complicated one for people who maybe want more detail in terms of what they should actually be doing. So thank you for both of those. I think we have time for maybe one question. So I'm going to, I guess, choose this question. For patients who have already received the PCV13 and the pneumococcal 23 vaccine, I understand that there's some shared decision making between patients and physicians in terms of thinking about whether to get the PCV20. And I guess I wondered what factors would go into your decision to say, yes, we should go ahead and give the PCV20.
Thanks. That's a really great question. I just had a patient this week who we had this discussion. So there's, unfortunately, there isn't enough guidelines out there to help us make these decisions. The thought is if they've had the 13 and the 23, that they're good. They are well covered. And they actually have to wait more than 5 years from the last vaccine that they had to get the 20 or 21. That's the recommendations. So some people say, I want the newest vaccine and I'll wait. And it's been 6 years or 7 years since I've had my last one. I want to get it. But I think it's okay to say to patients, if you don't get the PCV 20 or 21, you are still covered because the PCV 13 and 23 together have said that that's fine. That gives you what you need.
Okay.
It's, I guess, my whole that shared decision making comes when patients are asking for it because they're reading it and hearing it all over the news and they just want to know what they should be doing. So it's okay to say to them, you're actually pretty well protected.
Okay, good to know. Because I've certainly seen that recommendation too for shared decision making if people have already received the two. And it's interesting because older adults tend to have more uptake in vaccines, which is fascinating in the world that we live in right now. All right. Well, thank you so much, Dr. Agwani, and thank you to everybody who tuned in to listen. You have time now to go to study hall if you'd like to listen to some of the talks from yesterday, and I believe some of the talks from today have actually been uploaded as well if you missed any of them. And then, of course, some of the pre-recorded workshops are there too for your study hall to prep you for the boards. And we'll see you tomorrow at 8:30. Oh, sorry, at 9 a.m.